Radiation is another method to treat desmoid tumors. It's very effective at controlling tumors in about 70 to 80% of patients. It can be used by itself in patients that aren't candidates for surgical resection, or it can be used in combination with surgery to try to limit the chance of local recurrence. It can also be used to palliate pain. However, radiation is less effective in children, and it does have a risk of significant complications. Probably the most worrisome complication is the chance within the lifetime of developing a secondary malignancy. This is, of course, a particular concern in pediatric patients. Because of the limitation of the standard treatment options for desmoid tumors, we began to explore the use of MR-guided focused ultrasound for the treatment of these patients. Many of our initial patients had already undergone standard of care surgical resection, radiation treatment, and/or chemotherapy, and none of these treatments had worked well for them in terms of controlling their disease. Our more recent patients, however, have been patients that have just been diagnosed with the desmoid tumor and are being first treated with MR-guided focused ultrasound because it's the least invasive treatment option for this particular tumor. I'd like to review some of the treatment itself using these images to describe the steps of the methods. This is an example of a woman that had a large desmoid tumor in the right breast. You can see it here on this image as well as in the other planes of imaging. This was actually a recurrent tumor. The tumor had initially been resected and the woman had undergone a flap reconstruction. Despite that, the desmoid tumor recurred, and in an effort to avoid a second surgery, she instead underwent MR-guided focused ultrasound treatment. The patient was treated in a prone position. Here you can see the breast on top of a water bag. The ultrasound device is actually within the table below the level of this image. The first thing that we do is we delineate the skin line so that we can monitor for any heating on the skin. We then identify the location of the tumor itself so that we can target our treatment specifically to the tumor. In this case, there was a scar from the prior procedure. We were able to delineate that scar so the system could avoid traversing that area on the way into the tumor. Having defined the location of the tumor using this orange oval, we then plan the treatment. Each of these green rectangles represents a small portion of the tumor that's going to be targeted for energy delivery. The blue beam path shows the delivery of the energy from the ultrasound transducer, which is inside the table from the bottom of the image, to the focus within the desmoid tumor. Having treated one small portion of the tumor, we then march progressively one by one over the course of the tumor until we cover the entire volume of the tumor as completely and as safely as we can. This is an example of one of these energy delivery steps, which are referred to as sonications for the delivery of sound energy. What you can see is that the energy is being delivered to within, in this case, a yellow rectangle, and these images to the side are images that are being acquired every few seconds within the process of sonication. Here we have images that show the anatomy, and here we have images that are used to generate a temperature curve. The temperature curve at the bottom tells us that we've reached an adequate temperature for an adequate length of time to destroy the tumor tissue within this volume. Having done that, we then move to the next spot and the next spot until we've covered the entire tumor as completely as we can. Here in blue is the region of the tumor that has been predicted to have been destroyed by treatment. All of this is happening using the intra-operative thermometry process that I described to you earlier. This in-treatment verification, again, is then evaluated post-treatment using the contrast-enhanced imaging that we discussed earlier. Again, you can see a pretty good correlation between the areas that you previously saw colored blue that were predicted to be dead and these areas now within the tumor, which are largely no longer taking up the contrast. Only a thin rim of remaining viable tissue is present within the desmoid. The bulk of the desmoid has been killed by this treatment. In addition to the MRI obtained immediately after the procedure, which verifies the portion of the tumor that's been killed, we continue to follow these patients via MRI to evaluate for any residual tumor, to look for tumor shrinkage and regrowth. This is a good example of what can happen after a single procedure in a tumor that was fairly completely treated. Here's the tumor before treatment. Here it is months after treatment. And you can see again that there's been significant shrinkage of the tumor with very little viable tumor left. This is a summary of some of our treatment parameters. As you can see, these are very long procedures that can last hours. 4 hours is very typical. Patient positioning can add to this time. Anesthesia adds to this time. And a lot of this has to do with, as I said, positioning, but also the time it takes to deliver individual energy doses to small portions of the tumor, taking care to avoid damage to any normal structures. Here's a summary of our treatment results. We've treated more than 50 patients now. This is a summary of our first 40-plus patients. The average age of our patients was about 36 years, but as you can see, we've treated patients ranging from 4 years of age up to 66 years. On average, we followed these patients for more than a year with a range of anywhere from a month to almost 4 years. On average, we don't kill all the tumor. We're only able to safely treat a portion of the tumor, about 60%. Sometimes we can treat only about 15% of the tumor. Sometimes we're able to kill the whole thing. It typically depends on, as we'll see later, the proximity of the tumor to the skin, to scar tissue, to nerves, vessels, and also on the size of the tumor. In general, however, when we look at our tumor volumes before focused ultrasound and after, you'll see that there's been a significant shrinkage from the total volume before to after focused ultrasound. The results are even more impressive if you look at actually how much of the tumor volume remains viable after focused ultrasound treatment. Again, we're not able to treat the entire tumor in most of our cases, but we are able to get some tumor control with this approach, which also typically has minimal morbidity. In these patients, we define durable clinical benefit as seeing a reduction in tumor size of at least 50% and a reduction in pain scores by at least 2 points. And we'd like to see those results maintained for at least 6 months after treatment. Interestingly, even though we're only treating about 60% of the tumor, we can see dramatic improvement in pain. And in about half the patients, we see a durable result in terms of tumor shrinkage and pain control. In those without good local control, the common themes are tumors that are very close to nerves, tumors that are very large, very close to the skin, or if there's scars from prior surgery. All of these are obstacles to a complete treatment for us. In addition to pain relief and tumor shrinkage, we've also been looking at functional outcomes, and we ask patients before and after focused ultrasound to rate themselves in terms of their physical functioning, their emotional reaction to their disease, their level of energy, social function, and pain. And as you can see, in every case, we see significant improvements in patient scores after focused ultrasound treatment. I'd like to provide some clinical examples of the outcomes from some of the treatments that we've had. This is an example of a 14-year-old boy with a desmoid tumor in the palm of his hand. This tumor, as you can see, is very infiltrative. It's spread near the tendons in the hand as well as near the ulnar neurovascular bundle. Surgery would have resulted in significant morbidity and risk to these structures. Radiation was undesirable because of his young age, and so he was offered systemic chemotherapy. Instead, we treated him with focused ultrasound. We only treated a portion of the tumor in this case, and despite only a partial treatment, we got significant tumor reduction such that at follow-up imaging on the bottom right of the screen, there's no viable tumor left. Here's an example of his hand before and after the focused ultrasound treatment. This is another example of a 26-year-old young man who had a desmoid tumor as an adolescent in the shoulder. This area was treated with chemotherapy and ultimately with radiation. The treatment was effective in the shoulder. Much of the tumor that's left in the shoulder region was fibrotic. He did result in some side effects in that one side of his body is asymmetric with the other side in terms of bone and muscle growth. Despite the prior successful treatment, however, he ultimately developed a recurrence within the chest wall. We treated this again with focused ultrasound. We were able to achieve a complete ablation of this tumor in the chest wall region, and at subsequent follow-up now, he no longer has any residual tumor. Here's another clinical example of the use of MR-guided focused ultrasound in a 4-year-old with a desmoid tumor in the forearm here. You can see the tumor here and its relationship to the bones of the forearm. Here's another view showing the fact that the tumor is bulging out from the forearm there. This is the patient actually in position for treatment for focused ultrasound. she had already had treatment for a year with standard chemotherapy, which had not proven to be effective. A targeted medical therapy was chosen next, and she developed an immune reaction to this. And so subsequently, we proceeded to treat her with MR-guided focus ultrasound as another less invasive option compared to, for example, surgery in this case. These are images from this patient's treatment. Again, we see the tumor here in the forearm on this MR image as well as on this photograph, and we can see immediately after the procedure that the bulk of the tumor is no longer enhancing. There is some residual enhancement which could represent residual tumor and or inflammation related to the treatment itself. What's really remarkable about this procedure, though, speaks to what I had discussed earlier, which is that when we do these treatments and minimize any damage to the surrounding structures, the patient's recovery is remarkably fast. In this case, the patient a few days after treatment is back in her gymnastics class. There was some residual tumor, and we brought her back for a subsequent treatment. Here she is a few days after her second treatment, again playing in the snow. There are complications associated with this procedure, most commonly skin burns. Most of these are first-degree burns, which are like a sunburn, or second-degree burns, which are blisters. But we have had cases of deeper and more significant third-degree burns that have required surgical management. These tumors spread along the neurovascular bundle and can encase the nerve. Despite our best effort to avoid the nerves in all of our patients, we have had a few cases of nerve dysfunction after the treatment. In half those cases, the patients recovered function, but we have had a few patients with residual neurologic deficit after the treatment. Again, the things that limit treatment of desmoid tumors with MR-guided focus ultrasound are proximity to the nerves, large tumor size, proximity to the skin, and scars from prior surgery. There are a number of challenges that must be addressed before MR-guided focus ultrasound treatment of desmoid tumors and other soft tissue tumors can be more widely accepted. Patient positioning is a lengthy process. Aligning the desmoid tumor to the ultrasound transducer, which is built into the MR table, can be time-consuming, particularly with the patient under general anesthesia. A version of the device that is tethered to the table via cable would allow more natural positioning of the patient, with then straps used to position the ultrasound transducer on top of the tumor. Such a device would need to operate under a higher frequency than is currently available to therefore allow us to do smaller spots closer to critical structures. This device would also include a cooling mechanism. As visualized here, there's a membrane filled with cold water that's circulating throughout the treatment, allowing the skin to be kept cold while the deeper tissues are being treated. We also need a better understanding and more accurate volumetric thermometry. This would allow us to monitor thermal dose not just in the slice that we're treating, but on other slices, and also to account for dose that accumulates over many sonications. We also need a better approach to temperature measurement within fat and to integrate that temperature measurement to our overall treatment protocol. Finally, these tumors are very heterogeneous, and parts of the tumor are relatively easy to treat, whereas other portions are more difficult to treat. We need to understand this tissue heterogeneity and incorporate that into better treatment planning protocols. I'd like to conclude by thanking my colleagues at Stanford. These are the team members whom I work closely with in all of these treatments. Dr. Rafi Avedian is an orthopedic oncologist, Dr. Christian Ganju, a medical oncologist, and Dr. Lynn Millian, a radiation oncologist. We often see patients together in a multidisciplinary setting to evaluate their tumor as well as their treatment options and to plan subsequent management. I do these procedures with colleagues in physics. These are experts in both MR and ultrasound physics. Dr. Kim Butts-Pauley and Dr. Rochelle Baton work with me very closely and help to make these procedures as safe and as effective as they can be. Thank you for your attention.